Welcome, distinguished attendees. Good morning, good afternoon, good evening, and delighted to have you all with us today. I believe a lot of number has already joined, as I was told. I'm Neena Valecha, co-chair of IVEX Working Group. Formerly, I was heading Malaria Research Institute of ICMR and later was regional advisor at WHO CRO. With me is Caroline Leitch, who is co-chair of IVEX Working Group and regional advisor MMV. Manesh Shrestha, Technical Coordinator, MMV, and Ponce Hain, Associate Director, APMEN. And they are the ones who have put in all the efforts to organize this webinar today. Well, I'm sure you agree with me that malaria elimination is within reach, and many countries have already reached elimination. But still, in the countries where we have Plasmodium vivax, managing vivax infections requires precision, innovation, and persistence. We all know about the issues related to the relapsing vivax infections. Therefore, vivax working group, which facilitates relevant technical information exchange between programs and partners, brings to you today's session with focus on tafenoquine and primaquine different doses, and which are these are two pivotal anti-malarial agents for anti-relapse treatment of vivax malaria. And today, our expert panel will focus on effectiveness of tafenoquine and new regimens of primaquine, and hope they can be game changer in near future once everything is established. And let me give you some perspective of today's webinar. So Professor Kamala will present results of EFFORT clinical trial, which has been done in 4 countries. And Dr. Keogh will reflect program perspective related to pros and cons of introducing tafenoquine and short course high-dose primaquine in Laos, because besides the technical aspect, there are many issues related to implementation. And Professor Emeritus Dr. Kamini Mendes shall provide an expert commentary, including the current WHO guidelines and the recent studies on radical cure, and also if there are any questions. And let me give you some housekeeping announcements. Now, we will be disabling audio video of attendees, but we encourage the comments in the chat box, which can be done throughout the presentations, and speakers are free to answer in the chat, or otherwise we will also try to take them up at the end of the session after all the presentations. And the presentations, as I mentioned, after all the presentation, there will be Q&A and panel discussion. And please specify the speaker to whom you are addressing the question. And also, you can give other reactions by which we will know this thing. And after that, we'll have a quick poll. So now let me begin today's proceedings with the first presentation, which is from Professor Kamala Primer. And she is Principal Research Fellow, Menzies School of Health. Her work centers on optimizing treatment for Plasmodium vivax and developing public health strategies for malaria elimination involving clinical trials, epidemiological studies, and policy research. Kamala also teaches at Charles Darwin University Menzies School of Health and is an associate member of Australian Academy of Health and Medical Sciences. Over to you, Kamala.
Thank you so much for this lovely introduction, Dr. Neena, and hello to everyone. Very honored to be invited today and to speak to you about our trial. I'll quickly share my screen and hope everyone can see that well. So as Neena mentioned, our study looked at effectiveness and safety of unsupervised high-dose short-course primaquine and tafenoquine. I'll start with a bit of a background why we kind of went to do this study, and then give you a bit of an overview of the study design, and then focus on the main results. So radical cure is quite complex. We have a lot of treatment options that had been kind of coming to the forefront in the last couple of years. We know vivax malaria requires a combination of blood schizontoside treatment, so with chloroquine or an ACT, and then treatment against the hypnozoites in the liver to prevent relapse. And until very recently, and still a lot of countries use what we call a low-dose, long-course primaquine treatment. So a total dose of 3.5 milligram given over 14 days at a dose of 0.25 milligram per kilogram. But there are some issues with this regimen, as I think a lot of you will be aware of. We know that the adherence to this long prolonged treatment is quite poor, resulting in low effectiveness when it's unsupervised. And the second point, or the second challenge with this treatment, is that the total dose, so what we call a low total dose, the 3.5 milligram per kilogram, is suboptimal in terms of the efficacy in many areas. And therefore there are all these new kind of options thankfully now available, and I'll talk a bit more as to why, how they have been developed and why we have them, and how much they are better than those 14-day long dose treatment in the next couple of slides. So we know we can give the same dose over a shorter period of time to achieve the same efficacy when we fully supervise. And these two studies that you see here showed this, that when we fully supervise, we can achieve the same efficacy, whether we give it over that same total dose, whether we give it over 7 and 14 days. And the next question really then, what we try to address in this study is to really understand, well, if we give the 7-day primaquine in a less controlled setting, does this really help with adherence? And do we therefore have a better effectiveness? And really here it's important to understand the effectiveness as something that we measure when we are not supervising the treatment, whereas the efficacy is something that we measure when we fully supervise treatment. So the best potential option, which is really hard to implement in a real world setting outside a very carefully controlled trial. And so while we think that a 7-day course improves adherence, which is intuitively understandable, that as soon as we shorten the treatment, it might be easier for patients to take that treatment, but we actually don't know and don't have much data. And that's one of the aspects the EFFORT study was keen to generate some data. The second point why the low dose, total dose is suboptimal is based on this data that you see here, which was a large pooled analysis of more than 20 studies and 16 countries, nearly 7,000 patient records included, that showed that increasing the total dose of primaquine from the 3.5 milligram low dose that we have been using for such a long time to 7 milligram total dose, we can halve the rate of recurrent malaria. And this is the case in both high relapsing as well as low relapsing areas, and in almost all geographic locations. And this is really the reason the WHO has moved to recommending a high dose primaquine regimen in the latest updates of the treatment guidelines. But what about tafenoquine? Obviously, tafenoquine as a single dose addresses all those concerns we have around adherence, and therefore isn't affected by that gap that we're usually seeing between efficacy and effectiveness. But how does tafenoquine compare to high-dose primaquine? So there are actually no direct comparative trials to date, and I'll show you some data from our trial, which is the first one to show that direct head-to-head comparison. So tafenoquine was originally trialed against low-dose primaquine and performed actually a little bit worse than low-dose primaquine, as you can see on the left-hand side of the slide. But of course, this is, again, was done in very carefully controlled trials where primaquine was fully supervised. And the assumption is that the primaquine that you see on the slide here in green, the line would much more likely look something closer to the gray line where patients aren't receiving any radical cure because of this issue between efficacy and effectiveness, which is limited by the adherence. But tafenoquine in the licensing trials showed a risk of recurrence, showed an efficacy around 60% at 6 months. On the right-hand side of the slide, you see data from a high-dose primaquine trial, so certainly looks better in terms of the anti-relapse efficacy. But again, we have to be very careful here. This is not a direct comparison. And this is all fully supervised. So we don't know how that comparable effectiveness actually looks like in real world when we aren't able to supervise high dose primaquine. Then there is one last kind of introduction slide that I wanted to talk about to you. There is a particular interest in the effort study results, particular for tafenoquine in the study sites in Indonesia and Cambodia, which used ACTs as chisantocidal treatment. So I think a lot of you will be aware that tafenoquine was trialed originally with chloroquine as chisantocidal treatment. And then post-registration, one additional study was conducted, which was called the Inspector study. That was the first study to assess tafenoquine with an ACT, in this case, DHA piperequine, at a study site in Papua in Indonesia, on the far eastern side of Indonesia, a very high endemic place or region of Indonesia. And you see the results of the trial here on the left-hand side of the slide. The efficacy of tafenoquine with DHA piperequine was rather disappointing. You see it performed much worse than low-dose primaquine, and almost the same as not providing any radical cure, which is shown in gray here. And this study led to a label change to use tafenoquine with chloroquine only. And again, as I mentioned before, we used actually at 2 of the sites, we had ACTs used, and therefore those results are particularly interesting. So what is the overall aim of our study? We wanted to assess the effectiveness of high-dose primaquine when given over 7 days unsupervised and compare this with tafenoquine and with low-dose 14-day primaquine, as it was the standard of care at the time when we started the study, but still is the case in a lot of countries. And then, of course, we were interested in looking at the safety and tolerability of those treatment options. So how did we design the study? I'll talk you through this diagram briefly. We recruited patients into those 3 treatment arms that you can see in the middle. I'm not quite sure if you can actually see my cursor or not, but into the high-dose primaquine arm with unsupervised treatment over 7 days, tafenoquine arm, and the low-dose primaquine treatment arm given over 14 days. And really important, again, that treatment was unsupervised. So we really tried to mirror something that would happen more in real life, where patients get a bag of treatment and are sent home very often. And we wanted to have very limited patient interaction in that treatment period, so not to interfere with how patients normally behave. But of course, we also still wanted to make sure that we are able to look at the outcome and ensure safety. And at that time point, there was much less, when we started the study, there was much less experience, certainly with both high-dose primaquine and tafenoquine. So we tried to find a balance here, and you will be the judge of whether we found that balance. What we have included there is a visit on day 3, as you can see here, kind of in the bottom part of the diagram. And conceptually, we think of this visit on day 3 as a potential part of an intervention in terms of a pharmacovigilance, a time point that might be really good to use for both tafenoquine and high-dose primaquine. The study was conducted, as Dr. Nina mentioned in her introduction, in 4 countries. They were Ethiopia, Indonesia, Cambodia, and Pakistan. Patients were recruited when they had a Vivex mono infection, were 18 years or older, 16 years in Indonesia, were G6PD normal, which is really important and in line with the tafenoquine label, but also probably what we want to use for high-dose primaquine. And then had an HB of greater than 8 and a few other inclusion and exclusion criteria, and were then randomized into those 3 arms. Here you see our total sample size and the sample size per country. and a reminder on those different, highlighting again those different schizontrocidal treatments that were used with chloroquine in Ethiopia and Pakistan, DHA piperacin at the site in Indonesia, which was in Sumatra, very much at the other end than the study that I introduced in the introduction. And then in Cambodia, we used artesunate pyraneuridine. So what did we measure? Basically, we wanted to know how well do those different drugs work. So we wanted to look at effectiveness. And we usually refer to this as the risk analysis. So we looked at the risk of having a Vivex episode within 6 months. We call this kind of an incidence risk or a cumulative incidence. And then we compared the results between those 3 arms. Our primary comparison was the two different primaquine arms, and then the other comparisons we looked at as well. There are a lot of other endpoints in our effectiveness analysis, but I'll focus on the primary one for today's webinar. In terms of safety and tolerability, what did we look at? We looked predominantly, we're interested in hemolysis and gastrointestinal tolerability. Those are really the 2 main concerns, particularly with higher doses of primaquine. There are quite a few endpoints when we looked at hemolysis, and you see them here. So we looked at severe and moderate anemia. We looked at a big drop in hemoglobin, so more than 5 grams, and a big percentage drop to below 7 within the first 3 days of treatment. In terms of the GI tolerability, we looked at vomiting, nausea, abdominal pain, and then, of course, overall at adverse and serious adverse event that might have occurred during the treatment period and during follow-up. So what patients were we able to include into the study? We screened nearly 5,000 patients across those 4 countries, and then were able to randomize 960 that fulfilled the inclusion criteria, and they were in equal proportions in those 3 arms. You see the exclusion criteria here on the right-hand side. So patients were predominantly excluded because they either didn't have malaria or didn't have a Vivex infection. So they're either falciparum or mixed infections. So this is what we call the baseline kind of table. It's probably not worthwhile to spend much time here on this. Just kind of highlighting really that all the variables or the baseline data is very nicely balanced between the treatment arms. So these treatment groups were very similar. Overall, fairly young cohort of 26 years of age, predominantly male, with very similar parasite densities and G6PD levels across the board. So really just ensuring that, or just highlighting that those groups were comparable. So coming to our first question, how well did those different drugs work? What was the effectiveness of those 3 treatments? And this is really the main graph that I'm kind of wanted to show you today, and I'll try and talk you through this. So on the y-axis, we have the risk of having any Vivex episode during the follow-up. On the x-axis, we have the time. In green, we have the low-dose primaquine arm, where we give low-dose primaquine over 14 days. In red, the high-dose primaquine arm, and then in blue, the tafenoquine arm. And so what we see here is we have about 18.5% risk of having a Vivex recurrence if you take low-dose primaquine unsupervised, compared to only 13% risk of recurrence in the high-dose unsupervised primaquine arm, and 12.7%, so very similar, in the tafenoquine arm. And these are what we call the hazards ratios, so when we compare them statistically. But I think the graph hopefully tells the story quite nicely. So what can we deduct? What does this graph tell us? Certainly it tells us that when we provide high-dose primaquine over 7 days unsupervised, we reach a better anti-relapse effectiveness than the low-dose 14-day primaquine treatment, which was our control and is still the kind of policy in a lot of malaria endemic countries. Tafenoquine has better anti-relapse effectiveness than unsupervised low-dose primaquine. And remember, I showed you those early slides in my introduction when tafenoquine was almost similar to low-dose primaquine when it is fully adhered to. So we certainly see that gap that occurs when we are not supervising. And that means then that tafenoquine had a similar effectiveness to unsupervised high-dose primaquine. So certainly both tafenoquine and high-dose primaquine, very, very good options overall. I'll go now into the country-specific analysis, and although I know this is an APMEN webinar and Ethiopia is clearly not part of the Asia-Pacific region, I thought I'll keep this slide in here just because Ethiopia was actually the country with the largest patient number recruited. So the overall results that I showed you in the previous slide actually are driven quite a bit by the Ethiopian results. So the graph really looks very similar. Then moving on to Pakistan, slightly different, much lower risk of recurrence in this geographic region. And we know that relapses often occur later. So that's certainly one limitation of this data here, that we didn't follow up longer than 6 months and might have potentially missed late recurrences. Nevertheless, very similar direction of the benefit of high-dose primaquine and tafenoquine compared to the current policy. So we can certainly say from those two graphs that tafenoquine is highly effective in Pakistan and Ethiopia, which isn't included in the current WHO recommendation, which is very geographically focused on South America. So hopefully this is going to be helpful to potentially review those recommendations. And then moving on to Cambodia, where we used artesunate pyrineridine, so an ACT as schizontocidal treatment. Looking at the primaquine arms first here, probably as expected, with a benefit of the high-dose primaquine compared to the low-dose primaquine, as we have seen in all the other slides as well. But very exciting and surprising, probably, the very good efficacy of tafenoquine here in blue. Of course, please be reminded that those confidence intervals are quite wide, but certainly not what we would have expected based on the inspector study results, where we had a very high risk of about 80% recurrence with tafenoquine and DHA pibraquine. So very, very exciting. And I think we can, despite those large confidence intervals, we can certainly say that tafenoquine with artesunate pyrineridine is highly effective in this study setting. Moving on to the Indonesian data, where the study was conducted in Sumatra, not in Papua, and where we used DHA pibraquine. So it looks slightly different as the previous graphs. Very, very low risk of recurrence in both the primaquine arms, with no recurrence in the high-dose primaquine at all. But importantly, about a 22% risk of recurrence with tafenoquine. And again, if you compare that to previous data, that's certainly relatively good news. But the data is very difficult to interpret, and I'll talk a little bit more in the next couple of slides why this is the case. Again, of course, very, very big, large confidence intervals, which we have to keep in mind. So as I said, certainly high-dose primaquine highly effective in this setting. A bit of a question mark here around the tafenoquine DHA pibraquine arm, and I'll explain a bit more why this is the case in a minute. So in this slide, we have the inspector results that I showed in my introduction on the left-hand side. From a study done in the east of Indonesia, in Papua, where tafenoquine had about a 20% efficacy only, so 80% risk of recurrence. Whereas on the right-hand side, we see the effort data. So the curve is just flipped, basically. So it's plotted as a relapse-free probability rather than the risk of recurrence, so make it a bit easier to compare. Overall, relatively similar numbers in terms of sample size, but certainly, again, certainly a better result than we would expect if we put them directly to each other. But it is really important to note that while both of those studies were conducted in Indonesia, there is a large heterogeneity in Indonesia in terms of disease burden and the background risk. And one of the limitations, unfortunately, in the EFFORT study was that we didn't have an arm included that didn't provide any radical cure. So on the left-hand side in Inspector, you see in gray the arm that didn't receive any radical cure, which is our background risk. And we don't have that included in EFFORT. And when we look at previous data from other studies conducted in the same area than the EFFORT study site, that background risk is probably around 26%. And so not much off from what we are seeing in terms of results from the tafenoquine arm. But what is interesting to mention when we look at the timing of those recurrences, I put the straight line here at the 4-month time point, and in Inspector on the left-hand side, most of the recurrences had occurred before 4 months, whereas in the EFFORT study, they occur much later. And there is obviously, we'll have to be very careful in interpreting those, but the later those recurrences occur, the more likely they are potential new infections. And that's certainly what the molecular data potentially suggests as well. But so I think overall we can certainly say that we need more data to kind of answer the tafenoquine DHA piperacin study. But I think we can also fairly confidently say that what we have seen in the Inspector study is probably not only caused by a drug-drug interaction, but there might be something else going on. And we really need this additional clinical data to tighten those confidence intervals and have a better understanding what's happening there. And those studies are ongoing, so that's the good news. I'll move now for the next couple of slides to the safety and tolerability data. So I'll start with the hemolysis outcomes. You see them shown here on the slide again, the outcomes that we looked at. And so overall, very good hemolytic safety data. There were no patients that developed moderate or severe anemia. There were no patients that had a large percentage drop to below 7. And there were only 3 patients that had a large drop of 5 grams or more. One of them in the low-dose primaquine arm and 2 in the tafenoquine arm. All 3 of those patients had very, very high starting HBs, recovered very well, and that's what we kind of, I think, know that from other literature that those patients that drop most are the ones that actually start relatively high. So there is clearly no evidence of hemolysis after high-dose primaquine or tafenoquine in this G6PD normal patient cohort. Then moving on to the gastrointestinal tolerability and the overall adverse event analysis. This is a table showing the overall number of adverse events in the 3 treatment arms grouped by kind of disease types. And important here, I think, as we would probably expect, gastrointestinal symptoms are quite dominant. What is interesting, though, and important to remember from the when I showed you the study design, that we had those 2 additional visits in the tafenoquine arm that we didn't have in the primaquine arm, and they have certainly kind of or I would argue that they will have certainly contributed to underreporting in the primaquine arms compared to the tafenoquine arm. And probably quite surprising that we would see similar numbers of GI events in both the high-dose primaquine and the tafenoquine arm. Important, though, as well to mention that those adverse events were predominantly mild, what we call grade 1 events. So they were mild, self-limiting, not requiring any intervention. And there were just 2 grade 3 events that were also managed in the outpatient setting. In terms of SAEs, so the really bad events that happen, there were a total of 4. 2 of them we consider being drug-related. Again, GI symptoms with vomiting and nausea in 2 patients that received high-dose primaquine. So I think something that we are very much aware of. And then 2 additional events that were considered not drug-related. 1 patient who unfortunately passed away from a myocardial infarction, and then a patient who required an appendectomy in the course of the trial. So in conclusion, we can say from this data that high-dose primaquine given over 7 days in an unsupervised fashion has better anti-relapse efficacy than the control, the current policy in a lot of places. Tafenoquine has better anti-relapse effectiveness compared to unsupervised low-dose primaquine, and tafenoquine and high-dose primaquine performed approximately similar. Exciting data certainly coming out from the Cambodian side, where tafenoquine with artesunate pyraneuridine had a really good efficacy. The tafenoquine with DHA primaquine from Indonesia certainly requires a bit more data to get a better understanding on that, on the efficacy there. In terms of safety, certainly no evidence of hemolysis after any of the treatments in this G6PD normal patient cohort. Adverse events were predominantly mild, self-limiting, as certainly a signal around GI intolerability, particularly with those 2 SAEs that were also gastrointestinal symptom related in the high-dose primaquine arm. And I'd like to close with this slide, just really highlighting that such a large trial is a huge group effort. I'm privileged to present this on behalf of a lot of people, and particular thanks, of course, to my colleagues here at Menzies, but importantly to the study site PIs and their teams who've done all the hard legwork, recruiting patients and collecting the data. And also wanted to acknowledge the patients recruited into the study who came for a lot of follow-up visits, and thanks to our funders as well.
Thank you. Thanks, Kamala, for that insightful presentation. And, your expertise has provided such valuable perspectives, not only this study and other studies on the subject, which we have seen, which are already published, and we really appreciate your contribution to advancing knowledge, especially in this area. Although, as I mentioned, we'll have questions at the end of the session, but just 2 things which I saw in the chat, which are directly related to the study's design. There was one question was that how was the G6PD tested, and another one that whether primaquine was given on day 1, 2, and 3 along with the ACT. So since these are related directly, so we can respond to them today just now. And also, as you already mentioned, I mean, the new infections, of course, they will be uniformly distributed in all the groups, but that remains an issue whenever we do these anti-relapse study. So over to you, Kamala, for these 2 and the rest of the questions. There are many questions which we can take at the end of the session.
Yeah, thank you, Nina. Yeah, I just seeing all those comments now, amazing. The G6PD testing was done using the biosensor at the 70% threshold. And the primaquine was administered starting at the same time than the chizondocidal treatment. So on what we call day 0, or some call it day 1. So at the day of enrollment, basically, patients received their primaquine bag and their ACT or chloroquine bag with instructions how to take it at home.
Thank you, Kamala. Sometimes we say 0, 1, 2, and 1, 2, 3. I think you have made it clear. Yeah, fine. So as I said, you are in, please, the audience can put in their questions, more questions for Kamala. I'm sure there will be many and on this, because effectiveness is so important, as we see not only efficacy, and we saw the difference between 14-day regimens. Okay, now we move to the next presentation, and I would like to invite Dr. Keo for the same. And she is Deputy Director of the Center of Malariology, Parasitology, and Entomology in Laos PDR. She also manages the case management and surveillance unit, including the operational research, and coordinates with all research partners involved in the case management research. And she will be presenting the program perspective. As I said, implementation in the program is another thing after the efficacy of any product is established. So on the radical cure aspect, especially, it is important, as we have seen from Kamala's presentation. So over to you, Dr. Keo.
Yeah, thank you so much, Dr. Nina, to introduce me. Good morning, everyone. Thank you so much for inviting me to present the malaria VIVAC train and radicon treatment. I would like to share our experience for the implementation in Lao PDR. Yes, I have the 7 content. The first for introduction, the situation, VIVAC situation in Lao PDR, and second, overview about malaria in 2023 and 2024, and the third, the policy, the treatment guideline, and the fifth, and the fourth, disease PD test and treatment compliance, and fifth, the challenge of PV treatment, and number 6, tafenoquine study in Lao PDR, and the last perspective of Lao to tafenoquine and primaquine high dose. Yes, I would like to introduction the malaria VIVAC is now recognized as dominant species in Lao PDR. The number of Plasmodium VIVAC malaria outbreak report from Khamuan, Bogel, Sekong, and Salavan. With this outbreak, we respond the intervention, the task innovate like a reactive drug administration approach, and then the PQ adherence still be issue for the radicon in Lao PDR, and ongoing 5 year the research project, we have the collaboration with the Lomlu project to conduct the optimizing the dose of tafenoquine for the radicon cure of Plasmodium vivax malaria in Southeast Asia. We conduct in southern part of Laos. Yes, this slide to show the malaria situation in Laos in 2023 and 2024. The malaria case have the significantly decline in Laos PDR. Like you see the number of cases in 2024, the case is reduced 51% if compared to 23. And Plasmodium vivax continue to account for the majority of the malaria infection compared to 87% of cases in 2023 and 85% in 2024. You see the map on the case occurred in the southern part of Laos. Too many cases there. Yes, and then in 2023 we have the outbreak in the Nagai district. You can see the bar graph is too high. Yes. Next slide, please. Yes, for the PV hotspot in Laos, PV outbreak, one site in the 2023 in the Nagai district, Khamuan province, the number of cases positive more than 200. Yeah, and then 2 sites in the 2024 in the Salavan and Kalum, and 1 site in the Bogel. Bogel is a re-establishment. On this outbreak, on this positive case, we provide the AL plus primaquine, depend on GCPD. If normal, we keep the 7 day, the dose 0.5 milligram per kilo. And another we conduct the RDA is mean the reactive drug administration. We provide the pyramid 2 round, and for the Bogel we provide the chloroquine 4 round. Yes. This is the malaria treatment guideline. For the falciparum and malaria uncomplicated case, the first line we use the AL plus primaquine single low dose, and second line we use the pyramid or ASMQ plus the single low dose primaquine. For the severe, we use the artesunate injectable and quinine IV. On pregnant case, we use the AL. For the VIVAC, overlay and mix, the first line we use the AL plus primaquine. And this is pretty normal. We use the primaquine 0.5 milligram per kilo body weight, 7 days. If the deficiency L intermediate, we use the 0.75 milligram per kilo body weight 8 weeks. About the second line, we use the pyramid or ASMQ and 7 days or 8 weeks. On case pregnancy, we use the AL. About the BMW, we train them to treat the VIVAC 8 week primaquine treatment without the without the G6PD test. If I cannot refollow, they can treat the 8 week and then they follow after that. For the G6PD test in 2024, 93% of the PV case get G6PD test, and the G6PD normal 80%. You look at the number of percentage is too high. Yes. For the treatment, we have the 7-day and 8 week. 95% 2023 and 92 in 2024. PV case receive the radiquenquia, and less than 8% receive only ACT alone because of contraindication for the PQ, like pregnancy or underweight or in the remote area cannot access to the health facility. And in 2023, the National Treatment Guideline training to introduce the 7-day PQ treatment and report by DHS to when we train in 2023, the malaria network first, but not on health facility, and then we continue to extend to train then the health facility. For the PQ treatment compliance, start data collection since 2023, and data show the PQ daily dose is better complete than the PQ weekly dose. For the VMW, we take the Chiron to PQ compliance follow-up, monitoring like compliance or pharmacovigilance, view the palm or dam, and health facility is improved on the communicate by WhatsApp or by telephone when the community have the to resolve it. Next. Yeah, about the challenge of the PV treatment, the first for the referral system from the PPM. PPM is mean public-private mix, like a pharmacy shop and then clinic to service with assistant art. And then about the remote area cannot refer the patient. Some patient not agreement to refer to the health facility. And then number of case for the VIVAC is decreased, and some case receive primaquine treatment without G6PD, like aside the 8 week. Even the primaquine adherence is improved when compared to 2024 and 2023. We provide incentive to VMW to monitoring the compliance, the pharmacovigilance, and then report for data entry, but still have the issue like 8 week cannot follow up, something like that. About the tafenoquine study in Laos, simple collaboration with the Lomlu project, conduct the tafenoquine, like optimizing the dose of tafenoquine for the radiquenquia plasmodium vivax malaria in Southeast Asia. The study design, like a double by randomized superior trial. The study site in Gai district, Khammuon province, and then Samoy, Taoy, Salavan. Right now, we will extend to Tumlan district. The sample size 140 case and study duration the 5 years. Right now, enroll only 3 cases and complete 2 cases and continue to follow up 1 case. And our CDOT project will find the case more to enroll the follow-up. For perspective on short course hydroprimaquine and tafenoquine, Lao PDR implementation the short course primaquine 7 day by 0.5 milligram, and in the future we think about the high dose primaquine 7 day, like 1 milligram. And we think about the curate percentage of curate or relapse prevention of pharmacovigilance, because if the the result is good, we will support the policymaker to this and decision in the future to use the ILAO PDR. And about the short course high dose or tafenoquine, we apply Lao PDR simply need to pilot for before the apply is into the national treatment guideline. Every 2 year or 3 year, national treatment guideline, we will update the treatment guideline. If the study or pilot allow have good result or safety or high effective, may consider to the include in the new national treatment guideline. And we think about how can use the short course primaquine for the G6PD defensive patient, because we concern like they take medicine so long, week long, they don't like to take like I don't have the symptom, why I take medicine, or some case like go to outside, the VMW cannot follow up, something like that. Yes, Nick. About the conclusion, the PQ 7 days 0.5 milligram per kg have better relapse, prevention effectiveness than PQ 14 day, and good for ST like a altimeter plus lumefantrine with primaquine, and adverse event is mild. It is important to continue to monitor the primaquine effectiveness. Right now, the tafenoquine study in Laos is still ongoing and found the problem with the last symptom, because the malaria case is decreased every year. The tafenoquine might be more suitable for current situation in Laos than short course high dose primaquine, but we might need to more pilot or earn data for the decision making, like support the policymaker to decide how to use the tafenoquine in the future. Yes, this is my presentation. Thank you so much. Yeah.
Thank you, Doctor, for sharing your thoughts on implementation in the malaria program. And it's so heartening to know that I could see in the slide it was mentioned that the treatment policy is being updated frequently, and you are also talking about, the G6PD testing done or referral system, although it may be suboptimal in some areas. But definitely, if it is coming from the program, the issues like pharmacovigilance and doing studies with the new regimens and updating the policies. I mean, it's so good. Actually, all the studies, like Kamala presented, are for benefit of programs. And if programs takes it up in such a positive manner, and they are willing to contribute and do it's really good to know, and that will be really useful. And your question on short course use of short course primaquine for without testing of G6PD. I mean, these are the things which are being, debated, but I'm sure when Professor Kamini is presenting, she can consider this point also and respond, or otherwise we can have a discussion when we can talk about it. Thank you so much once again for your presentation.
Yeah, thank you so much, Dr. Nina.
Thank you. So now we are going into the last presentation, which is, of course, really important because it will be a commentary on including treatment guidelines and other data available and today's presentation. And Professor Kamini Mendes will be presenting that. And of course, I don't think she needs any introduction, but still, let me attempt. I mean, she's a malariologist, medical scientist, and public health expert, renowned for her contribution to malaria science as well as research, and she advises several Southeast Asian ministries of health, including Sri Lanka, and international agencies on tropical medicine, health, and disease, including WHO Malaria Elimination Oversight Committee, MIOC, and she's on the board of directors of APMEN. And she was, let me tell you, she was also instrumental for launch of WHO's flagship rollback of malaria program when she was a senior official at GMP, WHO. Over to you, Dr. Kamini.
Thank you. Thank you very much, Dr. Valecha, for that kind introduction. It's a real pleasure to join this group for a discussion and to be able to make a few comments on what was presented. So we heard, can I share my slide? I have asked, but yes, just a minute. Right, okay. So we've heard earlier in this program from Dr. Kamala about the results of the multi-country study, which was the EFFORT trial, which I think adds considerably to the growing body of evidence on anti-relapse treatments for Plasmodium vivax and ovale. So let me start by congratulating the researchers who conducted the studies in the 4 countries, and also the group of scientists who conceived of this study and supported and coordinated the work. Congratulations. I will try to look at the implications of these findings and the evidence that we have today for policy and practice for the prevention of relapses in vivax in countries. I'll also briefly review the current WHO recommendations on anti-relapse therapies, which many of you I know are quite familiar with, but simply for the sake of being systematic, let's run through the exercise. So currently, can I move my slide? Doesn't seem to be. Okay, so currently there are 2 medicines available to prevent relapses in Plasmodium vivax. Both are tafenoquine medicines, primaquine, possible for use at 2 total doses. And each of these doses can be given either as a short course of 7 days or a longer one, 14 days. And the short course obviously has a higher daily dose, and tafenoquine, which is a single dose treatment. Now, all the current evidence available to date indicates that the effectiveness in preventing Plasmodium vivax recurrences increases as one moves from the left end of this spectrum to the right hand. And as if the EFFORT study has confirmed, doubling the total dose of primaquine almost doubles the effectiveness of preventing recurrent infections. And the EFFORT study also shows that the 2 options, primaquine at the high dose and tafenoquine single dose, can be equally effective, as was seen in the settings of the trial. Now, the choice of a drug and regimen is very much dependent on the risk of acute hemolysis, which is associated with both drugs, tafenoquine and primaquine, in people who are deficient in the enzyme G6PD. And we know that in primaquine, the degree of this risk is fairly proportional to the daily dose. It's not the total dose. In G6PD deficient patients, the risk of acute and life-threatening hemolysis increases across the spectrum from left to right, and the reverse, the safety profile of these drugs and regimens decrease as we move from left to right. So it's a trade-off between these 2 aspects of safety and effectiveness, and assessing the G6PD activity in a patient has become critical to the safe use of these medicines. As you know, there are at present 2 kinds of near the patient tests to assess G6PD activity. The qualitative tests, which simply indicate if there is a more or less than 30% activity, 30% of normal activity in a person, or the semi-quantitative tests, which distinguish between 3 levels of activity, normal or high, which is more than 70%, between 30 and 70% of normal activity, which is intermediate, and if they are deficient, which is less than 30%. Now, let's look at the WHO recommendations on the use of these medicines and the regimens, and I will now start at the right-hand end of this spectrum. WHO has recently recommended the use of tafenoquine as a single dose with certain conditions. It's currently recommended for use in countries in the Americas only, and this is because the evidence which led to this recommendation was most robust in that part of the world. But this can change in the future with growing evidence, as was shown in the effort study from other parts of the world. Another condition is that tafenoquine can only be used with a G6PD activity of over 70%. And just a minute, I had trouble with the, okay. Also, WHO recommendation specifies that the recommendation is for use with chloroquine only as a schizonticidial drug. Now, and this would also change with now mounting evidence, as we saw from the effort study, that it's safe and efficacious with at least some of the ACTs. In this case, it was artesunate pyronaridine. Now, some countries have already adopted this, the use of tafenoquine as policy, limited to some populations and some situations. 2 countries in the Americas, Brazil has already adopted a policy of using tafenoquine. In the Amerindian population in the Amazon region, and the implementation is ongoing. And I believe Peru will follow suit. So that's 2 countries. And in Asia, Thailand is also conducting pilot implementation study at the Thai-Myanmar border, which is confined to the use of tafenoquine in district hospitals, not at the malaria clinics, not in the hands of the community health workers. And they are using, of course, a semi-quantitative assessment of G6PD activity. Now, the recommendation, of course, requires that tafenoquine be used always with a quantitative or semi-quantitative measurement of G6PD activity, which is also part of the label of the drug when it was registered. Now, WHO also recommends the high dose of primaquine, 7 milligrams per kilogram, both the 14-day regimen and the 7-day regimen. And but for the 7-day regimen, it requires the use of a semi-quantitative, at least a semi-quantitative assessment of G6PD, because a person has to be have a more than a 70% activity of G6PD when it is administered. So that is also a new recommendation. I don't know of any country at this present moment which says up to this stage that has adopted the high-dose short-course primaquine. But let's wait and see. I mean, that's something to probably to look out for. Now, WHO also recommends the high dose of primaquine over 14 days. And this, according to WHO, because of the low daily dose of primaquine, can be used with a qualitative testing, because WHO says it can be used in those who have at least a 30% or more activity of a G6PD. And according to Kamala's slides, I saw that several countries that are not endemic for malaria, UK, USA, and Australia, have adopted this regimen. But apart from that, I'm not sure of any others that have so far adopted this regimen. Now, the low-dose primaquine has been in use for quite some time, and it's obviously recommended by WHO. The 14 days regimen of the low dose primaquine, which is the one that most countries have been using for decades now, is, as we know and as we heard today, is the effectiveness is really probably quite low compared to the other regimens for two reasons. One is, of course, the total dose, but more importantly, it's the 14 days of patient adherence to primaquine, which really reduces the effectiveness. Now, the low dose but short course primaquine for 7 days, and both of these can be used with a qualitative test, is increasingly being adopted by many countries. As we heard, Laos, I think Cambodia, many countries in the Mekong region, but also many countries that have eliminated malaria and are treating now imported malaria cases have adopted the 7-day high dose primaquine. And and they're using qualitative tests. So these are the current WHO recommendations, and this is where the countries stand at present with respect to implementation. Now, where does this place countries with respect to a choice with the emerging evidence? I go back to WHO recommendations because the WHO guidelines provide countries with independent expert advice and guidance, taking into consideration not only safety, efficacy, and tolerability, but many other aspects, such as the feasibility, affordability, the cost, the gender sensitivity, equity considerations, and so many other factors. So the WHO recommendations are highly nuanced. And that is why countries are advised to take guidance from the malaria treatment guidelines of WHO. Now, but with emerging evidence from the trials, as we've seen with the effort trial, and the implementation experience with countries, which is increasing rapidly, WHO will and must review its recommendations with respect to, for example, expanding the geographical areas in which tafenoquine treatment and the high-dose primaquine can be recommended, and also the use of tafenoquine with triazonticidal drugs beyond chloroquine. So we've seen from the effort study that it works very well, even with some ACTs, in this case, artesunate and pyronidine. Questions still remain with DHA-piperquine, as commonly mentioned. There are also other developments in the pipeline which will make WHO move to the right end of this spectrum. And these are newer and better and less expensive quantitative or semi-quantitative tests for the assessment of G6PD levels. And there are many in the pipeline just now. And the availability of these improved tests will also make it safer in the hands of community health workers or health workers in general for prescribing whose tafenoquine and the high-dose primaquine for eligibility among patients who are deficient. And one of the main challenges today is actually not even assessing the G6PD activity using the semi-quantitative test, which is actually being done quite well by the experience of all countries. But it's whether the health workers at a certain level can be reliably entrusted with prescribing tafenoquine and the high-dose primaquine based on the assessment of the G6PD activity. So this remains a challenge. Now, I think the countries with the low burden of vivax malaria, those that have actually eliminated malaria, but still continuing to have imported malaria cases, whom they absolutely want to treat effectively to prevent relapses, to prevent the re-establishment of malaria. they are very well placed to adopt medicines and regimens in the right hand end of this spectrum. So high dose primaquine, as the effect study clearly shows, can be as effective as tafenoquine. Because in these countries, patients, both falciparum and vivax, are actually hospitalized, at least for the first 3 days of treatment. And so they are very well placed to assess quantitatively the G6PD levels, as well as be ready in the event of a hemolytic event for emergency treatment. But you might argue that the most effective anti-relapse treatments are most needed in the high burden countries where the incidence of Plasmodium vivax is very high and it needs to be brought down in order for the countries to eliminate malaria. Now, this is the dilemma here. Because in the high burden countries, the highest incidence of vivax tends to be in fairly remote areas, which are rural very often, where anti-vivax treatment has to be given mostly at the community level. And this is where the challenge is for prescribing tafenoquine and high-dose primaquine by the community health workers. And so that remains a little bit of a barrier just now. At the institution level, of course, in all countries, I would say, the assessment of quantitative assessment of G6PD activity and reliably prescribing the tafenoquine and high-dose primaquine short course can be safely introduced. But just now, countries need a little more experience with going into these regimens at the community level. Now, I think countries have a choice of, as Kamala clearly assured us, the high-dose short course primaquine, and between that and tafenoquine. And I believe countries might slightly veer to the preference of tafenoquine because it's a single dose. But the argument can also be made that the primaquine high dose short course might have a slightly better safety margin because it's given over 7 days than a single dose of tafenoquine. And also, of course, countries are quite familiar with primaquine as a drug. And tafenoquine is new, but we'll wait and see how countries decide. Now, so making the choice of what regimen to use is a complex one, considering the interplay between safety, effectiveness, cost, feasibility, and so on. But I think with increasing experience of these medicines and updating WHO guidelines, which will happen soon, the better and with better and cheaper and more affordable G6PD tests at near the patient level, we can expect the routine treatment to move towards the right end of the scale. Now, I'd like to, before I end, I'd like to try and remind those of you who are from malaria control programs in the countries who might be listening in, that while preventing relapses in Plasmodium vivax is a very important component for the control and elimination of vivax from a country or a territory, it is not the only strategy that can be used to reduce the burden of vivax. As you know, vector control and the use of ions and other measures to prevent mosquito bites is very effective in controlling vivax. And also early and effective treatment of acute infections of Plasmodium vivax is very important in controlling and eliminating vivax. Now, the proof of what I say lies in the fact that there are several countries in the world that have had a very high burden of malaria, vivax malaria in particular, that have eliminated malaria even in the last 10 years using existing tools. One example, one notable example, is Timor-Leste, a country that had a very high burden of vivax, which has reported 0 cases of malaria, both vivax and falciparum, in the last at least 4 years. And they did this by using existing strategies, by using very good vector control and providing very good access to early and effective treatment of acute infections, including radical treatment using, I think, primaquine for 14 days. It just goes to show that whilst we wait for the improvements in therapy and to adopt the newer medicines and strategies, which is, I think, very important to make the task of elimination much easier. But while we wait for it, we don't have to pause in our elimination efforts. And I don't think elimination in countries has to wait for any newer strategies, even in the case of violence. So I hope with that comment, I can end this brief commentary. Thanks. Thanks, Dr. Nina. Over to you.
Thank you. Thank you so much, Dr. Kamini, and for sharing your expertise. I mean, and especially the perspective from WHO guidelines and other implementation aspects. And I was going to say that, you know, your presentation, considering all this, will spark future discussion. But I already see a lot of questions in the chat, and there's so many issues which are coming up. And this is such a topic, you know, every time vivax relapses or treatment of relapses is concerned, there are so many unanswered questions. And of course, with studies like Kamala presented, now we are getting to know so much more, and the new tools as well. But still, a lot of questions remain. And of course, now I'll discuss the questions which have been addressed to each speaker. But let me start with the most difficult question, which was directly addressed to me. I could see that what could be the safer and more effective alternatives to tafenoquine in future. I mean, of course, there is the ongoing process of development of new medicines, and which is ongoing. So basically, till now, we have struggled as far as anti-relapse activity medicines are concerned. Is the safety, because most of whatever we have 8 immunoglobulins, and that safety in G6PD deficiency is a question, and then conducting G6PD testing at ground level has been an issue. So that is what the issue is. But there is in the lot of research going on, and even MMB portfolio, there is work going on at different levels of development on having medicines which have anti-relapse treatment and are safe in G6PD deficiency. Of course, it will be best to have an anti-malarial which has all the gametocidal and other activity on other stages. But that itself is another topic, may be discussed in separate forums. So, of course, we need to have more safe medicines which are easy to administer as well. Now, the another thing was related to the adverse event monitoring. So these are general questions, so I thought let me respond to that. So as such, for any medicine, there should be a what we call it pharmacovigilance system is in the country, not only for malaria, for any other medicines. There are those systems developed in some places, but many are functioning and many are not functioning very well. But specifically, it is mentioned, like when we talk, even the program guidelines, most of the countries, they do mention specifically for primaquine, because the point of care tests recently have been available, but they were not available most of the time. So that we should have a system in place where we can detect early any adverse event which has been detected, because primaquine has been given without, or is being given without G6PD testing. Of course, it is low dose and 14-day, which has less risk, as was explained. But definitely this adverse event monitoring system has to be there. And there was a question related to adverse event monitoring for tafenoquine. So whenever any new medicine is registered or, permitted by the regulator in the country, the data on the safety and data after marketing of that medicine has to be submitted. And there are guidelines of local regulatory committees. So for sure, when tafenoquine is introduced in any country, this type of information will be generated and will be given to the regulator. So for tafenoquine, definitely it will be done. And for other medicines, of course, the different programs have different perspectives available. So now, of course, I have a lot of questions for Kamala and other speakers. But since the last presentation, based on that, there were many generalized questions. So let me take up those first. Now, there is a question which I don't know if straightforward or not. So Kamini, somebody asked, what is the role of primaquine for mass drug, for MDA? Should it be recommended or will it be useful? There was one question in the chat. Kamini, would you like to take that?
Thanks, Nina. Yeah. So primaquine for MDA is not recommended by WHO. That's very clear. But countries have used primaquine. For example, Mexico has used primaquine in several rounds of MDA for Vivax control, and notably, DPR Korea has been using it for a very long time, quite successfully. WHO has done repeated reviews of the evidence and does not find it to have that, considering the safety concerns of doing this, of using primaquine on a large scale, it really doesn't come out as a recommendable strategy, and so it's not advisable, not at all.
Thank you so much. And it is mentioned in guideline as well, rightly, as you said, rightly, Kamini. And they were, the question of course, we know it again, WHO is very clear on this, on safety aspect in pregnancy and whether we need to give it in pregnancy or not. And it is very nicely mentioned that we could give prophylaxis with chloroquine in pregnancy, and after 45 days of delivery, primaquine could be given. So, so there was still a question in the chat that, if primaquine is recommended after delivery and given after 45 days, is there any safety concern? Kamini, would you like to address that as well?
I think not. I mean, ideally, if the child's G6PD level is known, then it's absolutely very safe. But that's difficult and it's not feasible in most countries.
Yeah.
But sure. I think one is fairly safe in doing that. Yeah.
Right. Thanks. And there was also a question on, safety of weekly regimen. So maybe I can attempt that, because, we are talking about daily dose, because if there is hemolysis, the new RBCs are generated. So if the regimen is interrupted or it is weekly, then the safety issue is not that much of concern. And that is why G6PD cannot be done. This is what is recommended. Of course, operationally, from implementation point of view, from compliance, we don't know. But still, that is a safer option if it cannot be done. And although G6PD is not being done at point of care or in all the countries all the time before giving primaquine, but still, the best practice statement by WHO is whether you are giving low dose regimen or any regimen of primaquine, as a best practice, G6PD levels should be done. But if you can't, then if it is clear that you are not able to do, that is what the WHO recommendation is, that you give it weekly dose. So anything would you like to add on this or
No,
correct me?
I think the evidence with the week, you're absolutely right. The concerns are that the adherence to a weekly dose is even probably less than the 14-day regimen. So that's a weakness with it. And otherwise, I think there is no alternative. But also, WHO has a little fine print there which says if a country is unable to assess the G6PD status, then a decision must be made on carefully assessing the need versus the safety concerns. So, and then some countries are in fact doing it, as you know. I mean, they're not testing for G6PD. It's not recommended, but they are carefully assessing the risk versus the benefit. And using, of course, nothing more than a 14-day regimen of the low dose. And that's actually the only possibility.
Thanks, Kamini. And again, so there was one question related to specifically, I mean, it was that what are the challenges of using tafenoquine in India? I mean, whether it is India or any other country, I think challenges for anti-relapse treatments remain generally the same, but it depends on the system or the earlier practices or guidelines which can vary. And of course, when the safety in G6PD deficiency is the main challenge, and how one can do G6PD levels at point of care. So let me tell you, studies are ongoing in India, and it is as of now, the medicine is not approved by regulator, but the studies are being done for that. And of course, in those studies, all aspects of G6PD testing and the safety and all these aspects will be taken care, and then we'll know more about it. And of course, so now there was a question related to how do we, because there is a risk of reinfection, and when we analyze data, definitely we are talking about the new episode. It could be new infection as well. So as of now, there was some question if either microscopically we can see. I mean, that of course is not possible. Microscopic picture will be same, but when there was mention on the CYP2DX D6 genotypes. So whether that can help us to definitely say it is a reinfection or relapse, and was this strategy used in the studies? So Kamala, I would like your intervention on this aspect, specifically when these studies are done, and how do we take care of that, and how do we interpret that, and whether this genotyping is useful and was done in those studies. Kamala?
Yeah, thank you very much, Nina, and thanks for those questions. So I think this is a general challenge with VIVEX studies or any malaria studies that as we follow patients up, they are obviously in their communities and are at risk of reinfection. And so unless we move them to a non-endemic place, we can't avoid that background risk. You would assume that that background risk is the same across your study arms. And so that the comparison, the difference that you're seeing is really the actual difference that the drug makes in terms of relapse risk. But it is incredibly important, and I think particular for the tafenoquine, DHA piperacin data, it's really important to understand that better. And having, ideally, you would have an arm that isn't treated with radical cure to really see that background risk. But I think there would be certainly a lot of people who'd raise concerns, withholding treatment that is now best practice, clearly. There are molecular methods. They are not as straightforward and easy as in falciparum, unfortunately. And my lovely colleague, Professor Sarah Auburn here at Menzies, has developed a lot of tools to help us understand and differentiate between reinfection and relapse. Of course, there is recrudescence as well, potentially. And so if we look at that molecular makeup, we can potentially understand and differentiate those new infections from relapses. And we certainly, that's in the pipeline for the effort data, not yet available. But that's certainly hopefully helping us to understand that better.
Yeah.
Leave it
Thanks.
at that.
Yeah. So was there any like of course the distribution will be equal in all the arms, and but in this study, and there's another strategy one can try to prevent new infections, and there was a question that how or whether there was specific effort done to prevent new infections in these study participants in this particular study.
So no specific in the sense that people were moved to non-endemic places, but certainly got a lot of advice on how preventive methods, and made sure that they had mosquito nets if needed, and those kind of things. But yeah, so there is certainly a proportion of those recurrences that are more likely to be reinfections. And again, I think, as I mentioned, those later ones probably are more likely to be new infections compared to the early ones. There is a lot, we don't know, basically.
Yeah, thanks. And one more, I thought that would be very relevant. It was mentioned why North Sumatra is selected instead of Papua for Indonesia.
Yeah, thank you. That's a really good question. And when I read that question, I had to go back many years, because that was done quite a while ago. And I think, if my recollection is correct, at the time we got the funding and designed the study, the inspector results weren't actually available. So there was no idea around tafenoquine potentially not working this well with ACTs, and the assumption was it's all going to be fine. I think the site in Sumatra was part of a much earlier study, which was called the IMPROV study, where we looked the first time at that 7-day high dose regimen with Professor Ayadia, and so of course kind of the natural progression to continue working there, and then that ACT story came on much later.
Thanks, Kamala. So, Dr. Keo, I mean, of course, now we have heard all the technical aspect, and then there have been a lot of questions from implementation point of view. So now that once we have this tafenoquine, we know the efficacy, and now we also have so-called point of care tests available. So, do you think that, considering the existing infrastructure or the keenness of the ministry and also the referral system, what do you see as future when we think about implementing this, and how important it would be from your perspective? And is it you think this can be done, and this will be safely done in the program from program perspective?
Yeah,
Dr. Keo?
Dr. Nina, yes, because in the future we will update the treatment guideline, and we are waiting the result from tafenoquine Ilau PDR, because I saw too many evidence, like a research from Dr. Camera, something like that. It's good for the tafenoquine, and we hope to use in the future. But before we implementation, we would like to pilot first. Yes. We would like to know, like the deficiency. We know deficiency allow about the 5%, but we think about the case in the remote area, like the tafenoquine we use G6PD normal, right? But how about the deficiency in the remote area? We concern like this.
Thank you. Of course, all those aspects have to be considered. Although there are many more questions and discussions can go on, but I believe these can be answered by email or otherwise in the chat. So I think it's time for us to conclude. So can I hand over to Dr. Phone for the poll, please?
Yes, thank
Okay.
you, Dr. Nina. I already launched the poll, so it's
Okay.
short and only 3 questions there. So I would like to
Okay.
encourage the participant to participate in the poll. So it's really helpful for us. Thank you.
Thank you, Phone. Of course, that gives us a lot of information to improve further if once we get these poll results. So I'm sure that everybody will agree with me that this webinar has offered real good insights into the complexities of Plasmodium vivax. Also, although we have not able to resolve all these issues, but still a lot of work is being done, and we are sure that we'll reach there. And that, because this is important if we want to have malaria elimination, because we have seen that this is the last parasite to go, and the areas where we find the number of cases decreases, we find more higher proportion of ilex malaria, because it doesn't need new infection, and there can be same cases which can keep on transmitting by way of relapses. And I extend my sincere gratitude to all the speakers for beautifully presenting, and also, analyzing the information available and their contributions. And let us carry forward today's discussion further, and from different angles, whether it is development of new medicines or its effectiveness or implementation in the program, which is very much needed. And of course, this will definitely drive meaningful advancements in global health. Thank you all for participating. Thank you very much. Goodbye.
Thank you so much. Thank you so much.